Of course, there's a lot of things that have to be developed. I am honestly at the beginning of developing something, and today I'm going to reveal just one part of it. And I think I can show you some clinical cases. All right. Like I told you, I'm not an Invisalign person. I'm not an aligner person. I'm more of a lingual fixed appliance person. I do a lot of lingual treatment. And mainly because I believe I can handle most of things by myself. Okay? So the first part is we have to have a lot of adult patients, not only teenagers, but also 20s, 30s, 40s, a lot of 60 patients in their 60s and 70s, and most of them need invisible treatment. Then we need to have choices, lingual or something else that is aligned. Now we have two main choices, lingual appliance and aligner or Invisalign or something else. Main thing was lingual fixed appliance that doesn't need patient compliance, and maybe more importantly, it's not really costly. So laboratory fee in Korea, at least domestic laboratory fee is just around $1,000, including the wire, bracket, indirect bonding tray, and everything. And the cheapest aligner sets will easily cost more than $1,500 or $2,000 in Korea. So it's mostly more than double the price. And then I'm wondering whether aligner will be of great help to my practice. And I'm still wondering why, wondering how. And then one day the patient came, who is the wife of one of the biggest companies in Korea, motor company. If I say the name, all of you without exception will know what that is. The biggest motor company in Korea and maybe in the world. She wanted orthodontic treatment, and of course I prescribed lingual fixed appliance. Made a bonded the bracket, and the next morning she called me, I cannot stand it. Of course, she's 50-something-year-old lady, and she couldn't stand all the impingement bracket on the lingual side. And it's very clear that even if lingual fixed appliance is not visible, it's not very well tolerated by many patients. It takes more time. How about the patient's adjustability to orthodontic appliances? This is one of the studies among millions of publications out there. In this article, they examine the pain level, eating disturbances. If it's high level, it's more discomfort. And then if you look at it, the recovery time, the red bar indicates lingual brace. Invisalign is used in this study as a representative of aligner system. Then as you see, aligner has the lowest score in terms of many different orofacial functions. And that's what happened to her. I removed all the lingual braces and then I prescribed the aligner, although I don't really like it. She liked it. I can wear it. So then I told her, you really have to wear it 24 hours a day, except for the meal time. And she said, yes. And then I thought, wow, this can be an alternative to lingual fixed appliance at some point. But then again, one thing that bothered me was type of tooth movement. As you all know very well, I can tell you, I am at a certain point where I can do most of the things I can do with a labial fixed appliance in the same way with a lingual fixed appliance. I have no problem. I reach that point, but I do know aligner has some limitation or problem in some specific type of the tooth movement. When it comes to anterior teeth, as you see over here, we are not sure if we can induce bodily movement of the upper incisor in extraction cases using aligner. What do you think? can we induce bodily movement of, for example, upper incisor in extraction cases using Invisalign or something else? What do you think? Any experience so far? What do you think? It's never possible? That's questionable, and I don't seem to find any problem in the rotation, lateral movement, tipping or something like that when it comes to anterior teeth. What about the posterior teeth? As a matter of fact, so far there's nothing much we can do. We can visualize the molar, yes, with a liner. We know that very well. But when it comes to root movement, bodily movement, forward, or not necessarily backward, forward bodily movement is largely impossible. So my first choice of when it comes to invisible treatment is nearly always lingual fixed. One thing is the post. Let's have a look at a 33-year-old lady. This is not a big deal, piece of cake, but one thing that bothered me was the severe extrusion of the canine. And also there was a pathologic migration of the lateral incisor, just like that. The extrusion of the canine, as you see here. She's 33, she wants invisible treatment, and then we have two choices, lingual fixed or aligner. What do you think? This is periodontium. And for this particular case, I chose lingual fixed appliance. First, because the level of the discrepancy. The vertical discrepancy is as big as a 3 to 4 millimeter between lateral incisor and canine. And this 3 to 4 millimeter this vertical discrepancy can be solved with a single line of wire if we use a lingual fixed appliance. According to the setup, we attach, and then we will use a friction-free system to be able to facilitate the leveling and alignment, and then we can close the space using regular lingual brace after intrusion, and then we finish the treatment this way. Didn't take fixed appliance in the second molar area because the molar relationship was perfect, and we gained nice intrusion of the canine, just like that, without jeopardizing the periodontal support around the canine area. So when it comes to vertical correction, just because we know that lingual fixed appliance has an advantage, I will still use a lingual fixed. Again, 48-year-old lady, tiny little problem, but just anterior crossbite up in the front, just like that. And she wants invisible treatment. Okay, not a big deal. You can put the braces on, the lingual side. But then again, what bothered me was anterior crossbite. She's an adult. The situation was she had a lot of previous dental history, including the orthodontic surgery, plastic surgery here and there. Of course, she went through regular orthodontic treatment without extraction. Then she wants invisible treatment. What is your choice? What is your choice? Basically, just because I don't want to, the only thing is, well, this is a piece of cake, just piece of cake. Anything, you can do anything, but you are not supposed to use a labial brace. What can you do? In order to correct the anterior crossbite, basically you are obliged to use anterior bite plate or posterior bite plate or bite turbo. That concerns me because the molar relationship is very well established. What's next? What if you use a liner? I decide to use a liner. I still have to be concerned about the correction of anterior crossbite in the lateral incisor area. As a matter of fact, I didn't pay attention to that. Why? As soon as you started number 1 aligner, bite is already raised, and then cross-bite correction just happens by itself.
Nó sẽ tự chỉnh. Bởi vì tôi dùng cái loại loại mà aligner số 1 này. Chắc ông thầy ông.
And it finished. Okay, not a big deal. Not a big deal. And well, treatment change included correction of the crossbite in the lateral incisor area. That's one thing. And no change in the molar relationship, but also change in arch form. What do you think? What do you think? As a matter of fact, it's not easy to change the arch form using lingual fixed appliance because you need a lot of manipulation on lingual wire. And then I didn't really pay attention, but it just happened by chance, automatically. And there's a relatively well-developed arch form if you compare before and after, especially the lower arch. So it feels to me like very simple and easy. Of course, it takes huge compliance of the patient. And root alignment was already good even from the beginning. No change in the profile, no change in the tooth position at all. So even if we were obliged to wrap around incisor and posterior all at the same time, the wraparound type appliance, including the anterior and posterior segment, will have some unknown advantage of raising the bite, which will benefit automatic correction of anterior crossbite in these adult cases. Do you see a little bit improvement in the smile arc? Yes, just a little bit, not a very big deal. So these days I'm honestly making a transition from lingual fixed to clear aligner little by little. But then again, just because it seems to work in some cases, it doesn't seem to work in some other cases, we really have to figure out the underlying biomechanics. I have to tell you, aligner is an extreme type of shape-driven appliance. You see a lot of beautiful clean check, this and that way. You still don't know whether it will work exactly in this way. For example, have a look at the bottom case over here. It's beautiful, but what I'm wondering is whether, have a look, whether we can move the molar without burning the anchorage, just like that. That's what I'm curious about. This is beautiful. You can do whatever you want to do from a clean check. You can expand the molar by 7mm, 8mm from the clean check, but this is just a clean check. You can move the canine by 7mm, no problem, but this is just a clean check. So if you keep renewing the aligner without knowing what's going on, you'll be jeopardized in the end of the treatment. Okay, for example, Invisalign is one of the representative aligner so far. This is mostly sold in the whole world, and you know very well you use a clean check to be able to simulate the treatment before the treatment. I'm not going to talk about IPR today because I hate to grind the tooth. Most of my patients really hate to get their teeth ground just like that. So what you can do is a simple simulation before and after. And if you care about soft tissue, for example, you make a transition from crowded tooth to aligned teeth. But in the meantime, you really have to pay attention to lip profile very much. And then there's a lot of negative results out there about how well Invisalign really works. I mean, it's a lot of negative results, and in reporting mean accuracy of 41%. And most accurate movements, well, this is already an old article. Most accurate movement was found in constriction. Least accurate movement was found in extrusion. and my students will memorize it. Okay, Invisalign has a weakness in extrusion. Invisalign has a strength in constriction, for example, and we don't know why. No one seems to explain why. If you find another summarization in one of the blogs in a website, it's very well summarized. It has a strength in distalization, expansion, and tipping movement of the incisor. There's not much of consensus in terms of rotation because many people would say it has a terrible weakness in rotation. You can tip the teeth distally, and you can, I don't think it's a torquing, it's again tipping. Again, general consensus is that it has a problem in limitation in extrusion of the tooth. Some says it has a strength in intrusion. There's not much a consensus, as a matter of fact. Someone says it has a strength in here. Someone says it's a strength in here. So, this is what I don't like about the world of Invisalign, world of life. Everyone talks about different aspects. Everyone talks about different things. And in contemporary orthodontics, well, clear aligner therapy works well in this and that type of movement, and clear aligner therapy does not perform well. Expansion. Of course, someone says it has a strength in expansion, but extrusion of incisors, as if it has a solid weakness in the vertical control of the tooth, and some rotation, particularly around tooth. It has a weakness compared to the fixed appliance. If the case has this and that problem, my choice will be lingual fixed appliance. Or the aligner will recruit this and that attachments. Wow, it's beautiful. Have you ever figured out this? Canine rotation, premolar rotation, there is an evolution of attachment. Still, no one seems to know why it has to be designed in this way. Why this way? Why this way? The only available explanation is from the company. We have to write it down, we have to memorize, or we have to follow their instruction. And then the procedure is, once you send the model to the align tech, they will give you the clean check with this and that attachments. And then you don't know whether it has to be this way or the other way around. Why rectangle? Why triangular? And it seems to make sense, but we don't really know clearly. And then the align tech, the Invisalign companies come up with a lot of ideas for better control of the tooth, saying that they are force-driven appliances. Is that really true? Okay, let's think a little bit about biomechanics. First chapter, shape-driven versus force-driven. Force-driven appliances will move the tooth using force. And then the definition of the force-driven appliance requires frequent reactivation. A lot of people in the world, they keep saying aligner or Invisalign is a kind of a force-driven appliance, as if a force-driven appliance is something fancy. No, it's just a type of appliance. The main thing, if you want to differentiate, make a differential diagnosis between force-driven and shape-driven, it's very simple. If your patient has the appliance in the mouth, in Korea, you go to army service, and you are absent for the next 6 months or 1 year of time. They go abroad for their study, US, for 6 months or 1 year of time with the braces in. Okay? If nothing happens in 6 months of time with the same brace, it's a shape-driven appliance. If something terrible happens with the brace you made, installed in the mouth, if something terrible happens in like 6 months of time, it's force-driven appliance. That's a bottom line classification. Now, you can imagine what will happen if your patient wears number 3 aligner, and then if she disappears for the next 6 months of time. Does anything happen? Does anything happen? Then it's shape-driven appliance, okay? Then it's shape-driven appliance. This is important. Shape-driven appliance will move the tooth according to the appliance shape, and it requires a long-term maintenance. If the patient doesn't show up and if nothing happens, then it's a shape-driven appliance. Again, why it doesn't seem to work for a specific type of tooth movement? Let's think about the material. I'm not going to talk about 1 layer, 3 layer, all those rubbish things. It's a bottom line biomechanics. Think about the structure of the aligner. What does it look like? What does it look like? It's a wraparound type plastic, alright? Wraparound type, first, it's a wraparound type plastic. Second, it's a horseshoe type appliance. Is that correct? It doesn't have a cross arch or something. I mean, they're evolving. So the bottom line is, it's plastic. It's elastic material. And if you compare the aligner to arch wire, is that edgewise or ribbon arch? One or two choices. Is that edgewise or ribbon arch? Think about the plate. Think about the plate attached on the buccal surface. It's an extreme shape of ribbon arch. Do you understand? It's an extreme shape of the ribbon arch. And ribbon arch has a flexibility in the buccolingual direction. It has a very high stiffness occlusogingival direction. Is that correct? Think about the plate attached on the buccal surface. So it's an extreme shape of a ribbon arch in terms of a mechanical property. And edgewise arch wire will have a flexibility occlusogingivally and it has a stiffness buccolingually. And second, have a look at the lingual surface. It's already, again, very occlusogingival extended plate attached on the lingual side. Is that correct? Then it's another ribbon arch. Now, one extreme shape of the ribbon arch on the buccal plate, buccal side. Another extreme shape of the ribbon arch on the lingual side. That's the nature of the aligner that has a little flexibility occlusogingival. But it still has a little bit of flexibility transversely. Third, how are they connected on the occlusal side? Let me tell you, you go to a line seminar, you go to Invisalign forum, you go to Invisalign whatever, no one talks about the biomechanics because they are interested in selling their own products. They will show before and after, before and after, before and after. You're mesmerized. What is the nature of the biomechanics of the aligner? It's extreme shape of the extremely extended ribbon arch, plastic, elastic ribbon arch on the buccal side, and again, lingual side, and the two ribbon arches are connected on the incisal edge and also occlusal surface. So it's like this. And then this is a horseshoe shape. So it has a little bit flexibility, buccolingually, maybe questionable, but it has a high stiffness occlusogingival. So it's very natural that it has a low flexibility buccolingual, which gives you a lot of weakness in the vertical correction, like extrusion. So once again, it's very well summarized that clear aligner has strength in this and that type of tooth movement, weakness in this and that type of tooth movement. It's efficient for incisor. Wow, you said it has a problem in the vertical correction. How is that possible? Intrusion may be facilitated because the incisor edges, occlusal surface is very well surrounded by the aligner structure. That's something. But the condition is, if you want to intrude 2 incisors or 4 incisors, the bottom line condition is, for example, your canine has to be very well grasped by the aligner. Do you understand? If the canine is away from the aligner, you are not supposed to expect any intrusion effect. Only under the condition incisor intrusion will happen. How about incisor extrusion? Not easy to extrude, intentionally extrude the incisor, and that's very natural. So these things summarized in some of the systematic review and meta-analysis, blah blah blah, are very relevant to underlying mechanical property of the aligner. Once again, let me tell you, the nature of the aligner is nothing but horseshoe-shaped, extremely extended ribbon arch that is connected through the incisor edge and the crucial table. And if you can imagine the behavior of the ribbon arch, you will understand why it works some type of tooth movement, why it doesn't work for some other types of tooth movement. That's very natural. Again, the same thing is highlighted by some of the articles when they tested 2 different clear aligner systems. It doesn't matter whether it's a 1 layer, 3 layer, and they have some difference among the aligner brands in their mechanical property, like flexibility and blah blah blah, but just a little bit. In nature, they are extreme shape of their ribbon arches. So they didn't seem to find a difference between clarity and Invisalign, and they also in common find some problem in the vertical movement and the rotational movement. So we need to first we need to understand the nature of the aligner. It is ribbon arch, and this is extended ribbon arch. Again, this is extreme shaped ribbon arch covering all labial surface and limbar surface. Again, it's extreme ribbon arch that has a connection at the incisor edge and a closer connection. So it has a high stiffness vertically. So it definitely needs, when it comes to vertical correction, you're going to need attachment for the tight grasp, tight grip on the tooth. Without grasping the tooth, we are not supposed to have good vertical correction. And it has less stiffness transversely. At least you can expect a little better correction transversely. That's exactly what happened in the previous case. Even if I didn't pay any attention to the arch form correction, it just happened, along with the crossbite correction. All right. So let's move on to a little bit. Don't expect a lot. I'm just at the beginning, like you guys here, and then we're just at the beginning. But I'm standing here just because I believe someone has to explain the biomechanics without showing before and after, right? Moderate crowding, not a very big deal. I borrowed this case to one of my students. She's a aligner user, all right? But we were in the same track. She knew orthodontics. This is not a big deal. But in Korea, you have to make sure, not a big deal to relieve the crowding this much, mild to moderate. But if we end up with like 1 millimeter flaring of the upper incisor, we are jeopardized. You want to make a decision today for non-extraction, then you have to make sure you are distalizing the molar without burning the anchorage. We know that very well. Dr. Sugawara is the first founder of the mini plate who distalized the molar. See? But he developed this because in Japan, like in Korea, if we burn the anchorage by crook-line the upper incisor, we are in trouble. That's exactly why this mini screw anchorage has developed and has been introduced in this world. And we're not sure if we can distalize the molar by burning the anchorage. Have a look. This is the case done many years ago, some years ago. And she, like myself, she didn't know what to do. She was uneasy. I'm still uneasy. So we were going to use a lot of attachment here and there, just to be able to have a grip on the tooth. Then the simulation was, okay, this is my hope. I want to distalize the molar, and then again, unlike the minuscule case, if it was a lingual fixed, I would definitely try group distalization. Distalizing 4, 5, 6, 7 as one unit. Of course, why not? That's efficient. But without the minuscule, we are obliged to move one after another, 7, 6. And you will say, hey, Dr. Lee, that's very stupid. If you move the 7, 6 will move forward. If you move 6 backward, 5 will move forward. Yeah, that's very reasonable. But this is a little strange. Something has to be done. You move the 7 using 12 teeth as an anchor, and then you move 6 again using rest of the 12 teeth as anchor. Why 12? Because you are grasping the 7 as well. This sounds very stupid. But many times it seems to work. So at the aligner 12, you start to find some space between 6 and 7, between 5 and 6, and we use the attachment. Now, this is something I have to explain. You have horizontal attachment here, vertical, triangular attachment here, 2 attachment on the central incisor to be able to rotate the central incisor. And what makes the difference? If I ask you the same question, is there anyone who can answer the question? No one. There's no one. That's the current situation of the line of biomechanics. Again, she used it, and we use a lot of attachment here and there. We start to see molar distalization one after another. This seems to be very, very stupid, and I'm still worried about possible burning anchorage. But if you look at the central incisor, it seems to be staying where they are supposed to be. And then again, in the meantime, like I told you, this decrowding not just happens by distalization. There was a tiny little distalization, but also the arch form changed just a little bit. Have a look at the canine and premolar area. Arch form is changing. We are expanding the arch, but we didn't use the RPE. It just happens. And in the meantime, we have to be concerned about posterior open bite because of the material thickness. It just happens so many times. And well, no matter what, we were able to align the central incisor just like that. Of course, in the meantime, you really have to use a refinement set. That happens so many times according to Nicholas Weid's study. Average number of a refinement set was more than 2 to 3 in average. So in average, most of our patients will go through 2 times, 3 times refinement set, meaning that initial clean check, initial visualization is not really correct. So that's a kind of obstacle that we have to overcome. Again, refinement liner number 6, just because we have to, this is a kind of a manipulation that we need at the end of the treatment. Basically, we have to use up and down elastics, just because we are concerned about the heavy contact up in the front. Sometimes I use a sectional liner, and okay, this is not a big deal. Also, you can appreciate tiny little amount of arch form change along with the molar distalization, especially in the lower arch. And now I'm a little bit concerned about the treatment outcome, just because she was a middle-aged Korean lady. we really have to look at the cephalogram. And it happens. I was a little bit surprised about the result. Okay, molar with self-distalization is one thing, not much tipping, but this superposition of central incisor happened just because the upper incisor was rotated in the beginning. So rotated in the central incisor has been aligned. This is expressed as if it was retracted. So anyway, we didn't end up with a burning anchorage of the central incisor. And then that stupid idea of sequential molar destabilization one after another seems to work. It doesn't make sense to me because one after another, like I told you, but aligner biomechanics uses all of the time. Whenever you move a single tooth backward, you use the rest of the 12 tooth as an anchor unit, which is different from our general idea. How about class 3 with crowding? This is asymmetry. What do we need? You can first procline the upper incisor. Second, you can retract the lower incisor. But if you are concerned about the soft tissue profile, you may want to minimize proclination of the upper incisor. You want to maximize retraction of the lower incisor. Then again, we are ready to use intermaxillary elastics. If we use the same thing using fixed appliance, you will definitely end up with a huge flaring of the upper incisor. Let's have a look. I'm also concerned. And in the meantime, well, as most of you are already very well aware of, we have to use a combined mini screw on one side. This is a pain in the neck because every time we give the new aligner sets, we have to tell them, whenever you wear the aligner, you have to combine it with the elastics inside your mouth. Unless the patient is really, really compliant, they're not going to comply with this. So the condition is we need to have a very compliant patient all the times in order to have a good results, just like that. Without the compliance, it's not easy. Well, at the end of treatment, sometimes it takes more time. See, have a look at the midline. It's a 0.5 millimeter deviation to one side. How old was she, by the way? This was teenage to a young adult. She had a good compliance, also with the mini screw. And just because she had an underlying asymmetry, just a little bit asymmetry in the beginning, this is decent outcome, but I don't really like the residual midline deviation of up in the front of 0.5 millimeter. But like you see, before treatment, it was an asymmetric case. Denture midline deviation is only 1 to 1.5 millimeter, but there was a lot more apical base midline deviation. Now I'm concerned about the burning anchorage. See, this is strange. This is strange. You know, many times, well, if you go to Invisalign seminar, they will keep saying, wow, have a look at this. You don't have a burning anchorage up in the front, even if we corrected the lower molar. I mean, even if we distalized the lower molar backward, what did we use? First, mini screw. Second, in the meantime, we had to use a class 3 elastics. And if you use, like I told you, if you use a class 3 elastics between top and bottom, using the lingual fixed or labial fixed, you will definitely end up with the incisor flaring to the front. But it doesn't seem to happen very much. This feels like strange. I was like, I had the same thing, I had the same feeling. And I kept asking my student, do the superposition again, do the superposition again. Is that correct? Just because you use class 3 elastics, we must end up with some flaring. Why did it happen? And then something tells me that it's a natural anchorage preparation. Do you understand? Think about the material property of the aligner. What is that? Is it very stiff material up in the front? Very stiff material in the backside of the incisor that wraps around the incisor, and then it's not easy to allow forward tipping. So if it happens many times, the side effect will happen as a bodily movement to the front. That really happens. If you go to Invisalign seminar, now have a careful look at the cephalometric superposition. Many times, in class 2 cases, you end up with a forward bodily movement of lower incisor. Only under the condition the patient has a very good compliance. Do you understand? Does it make sense? So, just because the material property of the aligner that wraps around the incisor, just like this, the burning anchorage doesn't seem to happen. So, and then we end up with more distalization and retraction of the lower incisor this much. Again, this seems to be a very stupid idea, but then again, because of something we don't even know, the burning anchorage doesn't seem to happen. And this is, again, advantage over fixed appliance. Now, you think about fixed appliance. What will happen? You use a 22 slot. You use a 1925, believing that 1925 and 22 is the biggest wire you can ever use. And the bracket wire play is again more than 10 degrees. If you let it go, at least you will lose 10 degrees torque forward. So that happens so many times, but it doesn't seem to happen very often in aligner cases. So then again, compliance is a must whenever you use